Thank you for being here today for this fireside chat on pharmacotherapy for sleep apnea, particularly with reference to GLP-1s. With me today is my friend and colleague, Dr. Robert Thomas, a professor of medicine at Harvard Medical School in the Division of Pulmonary Critical Care and Sleep Medicine in the Department of Medicine at Beth Israel Deaconess Medical Center in Boston, Massachusetts. Dr. Thomas specializes in sleep medicine. He's also a visiting scientist at the Martinos Center for Biomedical Imaging within the Department of Radiology at Mass General. Dr. Thomas has contributed to the development of novel diagnostic approaches to using heart rate variability, breathing signals, and deep neural networks for sleep staging and apnea detection. He's widely published and actively involved in advancing the understanding of sleep-related disorders through both clinical practice and academic research. Dr. Thomas, welcome.
Thank you. Happy to be here.
And I'm Gary Zammit, President and CEO of Clinilabs. So, Dr. Thomas, what got you interested in the field of sleep disorders?
It's an interesting backstory. It turns out I was interested in sleep medicine, at least sleep, even in medical school, and certainly during my internal medicine residency in India. And then when the first edition of Principles and Practice of Sleep Medicine came out, I requested my father to send me some extra money so I could buy it. And I may have been the only one in the country who actually, outside a library, who bought an actual textbook of sleep medicine. And I read through it, and I always thought it'll be a side gig. I didn't think it was going to be mainstream. My goal was to train in epilepsy, neurology and epilepsy. But after I came to the US, and one thing led to the other, and I was doing a sleep fellowship thinking I would do neurology after that. But then I was offered a position, and it was at Harvard and all those good things. So I said, well, let me give it a couple of years. And now it's 28 years later.
So it's become a life mission. And when you contacted your father, you didn't ask for beer money. You wanted money for books.
That is the only way to get him to not ask questions, books.
So what got you interested in sleep apnea in particular?
I thought that by the time I was doing my fellowship, that all the questions about apnea have been sort of sorted out, but the brain was less sorted out. But very quickly, once I started, it was evident that it was not quite true, that there were numerous sleep breathing questions which were utterly unanswered, including impact on the body and brain, and how you score, how you characterize. It was fascinating how often I was told why something was done, because that's the rule. That was the response. Why 10 seconds? Well, that's the rule. Why 75 microvolts? Well, that's the rule. It didn't make much sense. So when I was looking at data and learning, of course, sleep medicine, I started being more open with my approach rather than trying to just do what was done copy paste, trying to be more open. And I had a pretty good background of neurophysiology before I came to the US, training in neurology in India. So many things just sort of fell into place. And then I think I'm pretty good at patterns, pattern recognition. I'm pretty bad at many things, but I'm quite good at pattern recognition, whether it was radiology or pathology or neurophysiology. So, and I started noticing things which others did not. And then with some good luck and good collaborations, lots of serendipity, one thing led to the other and led to the other. And it turned out that many of my clinical observations actually were supported by math. If the math says something, it probably doesn't lie. These days, you had to add a probably to everything thanks to AI. So anyway, at the same time, my interest in the brain, of course, never stopped. So I've done a lot of work on the impact of sleep on the brain, functional imaging, structural imaging, epidemiology, cognition, dementia, etc. But the breathing part, which almost was like a little hobby, has become a major part, but mostly in complicated apnea syndromes. There are lots of the thousands, tens of thousands of people who can take very good care of obstructive sleep apnea. I can't offer anything special there. But with mixed physiology apnea, central apnea, that's where my clinical expertise is. And of course, in relation to today's talk, I've pretty much used every on label therapy and plenty of off label therapies for sleep apnea.
So it sounds like you started out with a lot of questions that challenged the status quo and then looked for evidence to find answers to those questions. And it also led you, I think, into the world of pharmacology, of medications that might be used to help treat people with sleep apnea. Tell us about how you got into that part of the field.
It was thanks to opiates more than any other. So at that time, opiate induced respiratory disorder it didn't quite have that label, but those of us who practice medicine, certainly my teacher who had been in sleep medicine since the early 80s, they had seen a lot of pathology, sleep pathology in folks on opiates, especially methadone and such. And they were hard to treat, and clearly there was a breathing control component. And acetazolamide has been around, of course, for a very long time, used for high altitude and glaucoma and so on. Was well known to help stabilize breathing. So I would, with back against the wall, I would try using some fairly high doses of acetazolamide, often in the range of a gram or more, like high altitude doses, essentially. And found that it really made a difference if patients could tolerate it. But over the years, a bit of mission creep. First it was extreme opiate-induced CSA, and then milder opiate-induced CSA, then non-opiate-induced CSA, then periodic breathing. And so now I use it very frequently for patients with what I call high loop gain obstructive sleep apnea. We have software, and also, we have figured out the morphological patterns of disease. I personally have over 500 patients on either acetazolamide and a smaller number on zonisamide, targeting high loop gain. So that is the carbonic anhydrase inhibitor story. At the same time, my teacher, who her name is Jean Matheson, I need to give a specific call out for her. She had great intuition. She knew exactly who needed what. Didn't publish much. So she transferred some of her wisdom to me, and hopefully I've built up on that. But she knew which patient needed a sedative. Now I know that it's those with lower arousal threshold and such. So we were using clonazepam as the popular thing. And we would use, just by reading the then paper PSGs, she would say, this one's probably going to need, look at that, look at that fragmented sleep. Not just the breathing, but look at the impact of that. So I've been very comfortable using sedatives in patients who have fragmented sleep, mostly non-REM dominant apnea. In REM sleep dominant apnea, sedative's not a good idea. But those who have persistently fragmented sleep is usually in non-REM sleep. So we have several hundred patients using low doses of zolpidem or doxepin or any tolerable sedative, essentially. And now you see publications coming out about the orexin antagonists and apnea and comorbid apnea and insomnia. So it's many good ideas start with just simple observations, and sedatives is definitely. I also look at oxygen like a drug and use that for people with central sleep apnea. They may not desaturate much. And once Andrew Wellman and his group published about atomoxetine, oxybutynin, I started testing it out off-label. So I'm happy to get any inch against the enemy by any reasonable means. Of course, I have to discuss carefully with the patient. They need to know that it's off-label and there are certain risks and so on. Now, the GLP drugs, I have about 15% of my patients are on GLP drugs, mostly diabetic. So my experience has been mostly with diabetes, though now the last 6+ months, I'm seeing, non-diabetic. And diabetics didn't lose weight like crazy, not at the doses which they were using. They would lose, 5-10% body weight, and rarely could they get off. But bariatric surgery, a lot of experience with the sleep side of it from the 90s. So I have a pretty good idea what happens when you lose weight. And more or less about a third of them are essentially cured. The others still have ongoing apnea of various severities. And then the patient has to decide what they want to live with.
It sounds like your clinical experience and your experience with patients really drove your thinking and your research into the field. Is that true?
Yes, I was actually doing a back of the envelope calculation yesterday. I was having a little, not argument, but a discussion with one of my research colleagues about, the various secondary analysis of clinical trials, which is very popular in sleep medicine now, because we don't have very large scale primary trials for various reasons. And I estimated that I personally have seen about 15,000 patients on my own.
Wow.
That is, new patients who I've evaluated and managed, and read probably between 30 and 35,000 sleep studies. And while developing the different softwares I have developed, looked at tens of thousands of sleep studies, epoch by epoch by epoch. And there are themes which fall out. Unless I am a total idiot, I will see themes. People see themes when they experience a certain country, a certain countryside, a certain food. After a while, you keep going to Chinese restaurants, you get a sense of what that style of food is, at least Szechuan or whichever it may be. You can't not learn from that experience. You don't need to do complex math to learn from experience. So those who don't see patients but do research, they do run the risk of generating hypotheses which make no clinical sense. It may make some statistical, mathematical sense, but no clinical sense. For me, it was all about, and is all about, identifying a vexing problem and trying to figure out a way to improve the situation. Sometimes starting with single patients who have unusual, either negative or positive response to something, and then trying to work backwards. And then I get an idea, and then I recognize there are similar patients to that one patient. Let me offer you this or offer you that. And then when it seems like a good thing to do, then I realize, oh, I better do some research on this and publish it. So in some ways, I work backwards. There are many kinds of discovery, right? You can go completely blind, unsupervised, and get tremendous insights. But you can let the patient drive the thinking also. You need all kinds of discoveries. It's not only the large data kinds of discoveries which matter. Many great discoveries in medicine, surgery, and sciences have started with simple observation, sometimes in nature, sometimes total serendipity, lithium as an example, or penicillin story. Of course, everybody knows the penicillin story and so on. So I think discovery comes through many ways, and I've been lucky to have the capability, I guess, to translate observations ultimately into generalizable ideas and treatments. It takes a long time. It takes 20 years, more or less, from observation to now it's a possible FDA-approved thing. Maybe less than 20 years sometimes, but it takes a long time. And of course, along the way, some ideas will turn out to be wrong. So you have to be willing to do that. Not every startup succeeds, right? So some of this is almost like a startup mentality where you're trying to figure out something for the benefit of a patient, of course. And then some of the ideas will turn out to be not true. It's You have to be ready for that.
Yeah. 20 years, thousands of patients and thousands of sleep tracings read lead you down to these different pathways. Um, Tell us, let's backtrack a little bit. Tell us how we define sleep apnea today. And what are the different types of sleep apnea, particularly uh, one type that you've published on, complex sleep apnea? How do we define these things?
So when I started in sleep medicine, it was fairly obstructive versus central. And you scored central apneas where there was no breathing effort at all and there was no airflow. And then everything else was obstructive. But even in the 80s, there were individuals who were publishing on the role of periodic breathing causing obstruction and such. They were sort of shouted down. And the fact that CPAP seemed to be so effective in, at that time, extremely severe apnea patients in the 80s and such, it saved their lives, basically. CPAP got this kind of godlike aura around it. And of course, if someone didn't use it well, it was just their own fault. And this field has sort of slipped into a mode where if you don't use your therapy, you're not trying hard enough or you're not worthy enough to have that therapy, if you go by the letters patients get from payers anyway. So I was noticing when I was a fellow, in fact, in 96, there were some patients who said CPAP doesn't work. And I said, that's like impossible. What do you mean it doesn't work? No, I'm using it. I feel worse. I said, oh, really? But it kept coming up as a theme for a subset of patients. And I would call them CPAP resistance. I would call them affectionately the complainers. Maybe that was not a good thing in retrospect. But anyway, it was to kind of, these are the people who seems to have trouble and give me trouble. And I started noticing that most of the disease was in non-REM sleep. And that in REM sleep, they were fairly easy to treat. But I woke up one morning and literally realized these patients look like they're at high altitude. And that was the moment where it all became clear that these patients who had non-REM dominant sleep apnea, and the respiratory cycle lengths were short, just like high altitude. And they're the ones who did great in REM sleep. So we always declared success on CPAP. But when I went and looked at their non-REM sleep, of course, it was not so good. And it had to be a high loop gain because at high altitude, periodic breathing occurs due to hypoxic sensitization. But these folks persisted in doing that despite hypoxia being treated. So clearly there was something more to it. Now, I was trying to explain to the technicians that, there's a domain of severity, but you may have a straightforward response. But there's a domain where it's variable severity, but CPAP doesn't do very well. So it's a complex response to CPAP. And so I said, think of it as complex apnea. So the term was originally used to explain to technicians that severity alone is not the only domain, but it's a complexity domain of the response to CPAP. So you got to recognize those who are not having a straightforward linear response to CPAP, and they have non-REM dominant disease and they have high loop gain. And these are the things you can try doing, like dropping the pressure, turning them on their side, trying oxygen. This is around 99, 2000, thereabouts. So I shopped around this idea of complex apnea. And of course, I just finished my fellowship, right? I mean, people shouted me down pretty much. And trying to publish my first paper was extraordinarily difficult. Reviewers ripped me apart, calling it old wine in new bottle and stuff like that, Then, but David White had more wisdom than most. And he was a then editor of Sleep, and he shepherded my case series through. It is non-REM dominant sleep apnea. And then shortly after that, I wrote the first article on calling complex sleep apnea. But essentially, it is high loop gain obstructive sleep apnea. So you have both respiratory control dysfunction as well as upper airway anatomical compromise. And now we know that about a third of patients have strong respiratory control instability as a key driver when they otherwise would be called obstructive sleep apnea. Work from Andrew Wellman, Scott Sands, they have shown fairly conclusively that there's a subset of patients who behave differently. They are also getting pushback. There's lots of pushback from this idea that, because when you say there's a different mechanism, it also means that maybe opening up the airway won't work all the time, completely all the time. And then there's papers published on residual apnea, etc. And now Sultam is being developed by Apnimed. Estazolamide can be used off-label, of course. And we have published, others have published the value of using acetazolamide, but mostly in central apnea, although we published on using kind of presumed high loop gain, those who have persistent instability on CPAP. I mean, why should they have that? Loop gain is one of the mechanisms, a low arousal threshold. And low arousal threshold is not just respiratory. These are people whose sleep is very fragile. They have a low arousal threshold to anything, really. But the respiratory arousal threshold is a good surrogate of this not enough glue of sleep, glue holding it together. So instead of being a self-sealing tire, the sleep system blows out, and then there's this big arousal and awakening and so on. So I would actually like the term complex apnea to be retired. I would like the phrase treatment emergent central sleep apnea to be retired, because that is not a disease. That's just the consequence of applying the wrong treatment to someone who has substantial breathing instability. It should just be called high loop gain sleep apnea. And under that, you have central sleep apnea, periodic breathing, non-REM dominant apnea, high altitude, heart failure. All of it comes under high loop gain sleep apnea. And they all have a certain pattern to their sleep breathing, and they all have a response to stabilizing influences, whether it is CO2, O2, acetazolamide, and so on. So the word complex apnea is very useful for patients to understand. So they understand that this is OSA, but there's more to it than that. And patients have no trouble understanding breathing control instability. You can use analogies like a rocking boat, a bad thermostat, and they get it, It's only sleep physicians who have difficulty moving beyond what they have learned. Changing practice is not easy. Very, very difficult. And the standards, the American Academy of Sleep Medicine standards, is still very, the term used is what, vanilla? It's very non-controversial, very simplistic compared to what we know today about the biology of disease. Not 30 years ago, understand. But today we know so much more about the biology of disease that not incorporating the various endotypes and driving the understanding of the impact of endotypes, you really can't get funding from anybody to do maybe 1,000 or 5,000 patients study looking at endotypes. Acetazolamide is generic. Sedatives are generic. People are still going to kind of use CPAP most of the time. Who's going to fund it? The NIH will be lucky to get any funding anyway. So it's no man's land. So they indulge in secondary analysis of clinical trials, and you can go only so far with that. People who have breathing control instabilities, they use CPAP less. They give up more frequently because it doesn't feel right. When your breathing rhythm is going back and forth and you're trying to breathe with it, it must feel uncomfortable. So we have a program in my center, which I kickstarted, but now there are other people who also are part of it, where we try to salvage CPAP failures by trying to figure out, is it a behavioral failure? Is it a biological failure? If it's behavioral, is it socially driven? Is it personality, like, why is CPAP not usable? Or it's just too much work. I mean, I perfectly understand that. But analogy I use is it's not like using insulin every day. You know, they can relate to that, but still, CPAP is a lot of work. And then the biological part, breathing control instabilities is the most targetable thing. Sedatives, don't really want to use sedatives long term. So we try first kind of aggressive cognitive behavioral therapy. But still, some people just have fragile sleep and they need something to help their sleep. Like you may be a really good eater, but if your cholesterol remains at 300 fasting, time comes when you go to either take the consequence or bite the bullet and start taking medications, right? So some of these patients, they have to bite the bullet. And physician too, you're prescribing it, you're very off-label, So we can salvage most patients, not all patients. I think we can salvage about 80% of CPAP failures. But there are about 20% where it's a very complex set of things. Everything from, every part of the body and mind is against CPAP, and it's not going to work. And now weight loss has become, of course, we always preach to the patient, right? Lose weight. And they come back, they're 5 pounds heavier. Lose weight. 6 months later, they're 5 pounds heavier. So that was not a winning strategy. And the patients who went for bariatric surgery, the bar was high. Getting approval was also not easy. And often the payer would say, go lose 20 pounds and come back. I mean, stuff which was just not going to work. For those who did have surgery, it was fascinating to see a small number of patients convert to central sleep apnea. Presumably they had more mixed physiology, but they had so much obstruction that we didn't see it really until they lost weight. Or they're deeply disappointed because they were not cured of apnea. In unselected patients with bariatric surgery, I would say that only about 30 to 40% really have no apnea at the end of it. Others have some apnea, sometimes a lot of it, sometimes not so much, sometimes treatable by body positioning or an oral appliance and so on. But about a third of patients, this is people whose BMIs were in the 40s and higher, they did not resolve because the weight was probably not the primary driver. So it comes down to depending on your population and comorbidities. See, when I started in sleep medicine, about 30 to 40% of patients coming to sleep lab were middle-aged males, obese, dying in their sleep with sleep apnea. That's a much smaller proportion now, maybe 5 to 10% at most. And you have a massive expansion of the edges of the then distribution. You have lots of younger people, not so severe. They're affected badly. Yes, that's why they come to the sleep clinic, of course. But their disease is just not that severe. And then you have the older, sicker people. I'm seeing patients for the first time in their 80s. I mean, they want to sleep better. I said, no worries. If you're willing to, come along with the ride, we'll take you along. But there are some challenges because of other comorbidities and so on. But older, sicker patients, those with atrial fibrillation, Parkinson's disease, heart failure, we actually have a sleep Parkinson's program as well as the atrial fibrillation program where there's a near routine screening for substantial apnea in people who are going to have a cardiac ablation procedure. And certainly those who need multiple cardioversions and such, a sleep evaluation is almost mandatory to look for more than mild apnea. If it's just a little bit of apnea, it's all right. But often they're not symptomatic. So once you go into that population, you're just going to get more mixed physiology. Why would you not? There's a little bit of diastolic dysfunction or systolic dysfunction. We no longer see frequently those huge myocardial infarctions, anterior wall, in the pre-interventional cardiology days. I had patients who would convert from OSA to CSA after a huge anterior wall MI. I just don't see that anymore. Cardiologists have become very good at salvage, which means now we have people living longer and longer with borderline cardiac function, and it shows up in sleep. Even if they don't have daytime symptoms, that subtle change in loop gain from subtle changes in left ventricular end-diastolic pressure or atrial pressure, triggering pulmonary reflexes, and it all converges into the brainstem, which gets all these, numerous physiological information. Our physiology is being tracked all the time, right? So the brain knows what's going on. So it starts getting this weird stuff. It changes the respiratory oscillation somehow. And we end up with periodic breathing and non-REM dominance, or they'll have a REM apnea also. But when you treat the REM apnea, you still have ongoing non-REM disease and so on. So that part has, really massively increased. It also depends where you are. If you're in a major metropolitan area with lots of sleep service availability, we have taken care of a lot of the very, very severe classic OSA patients. But once you leave the surrounds of the big cities, maybe half the country, it's still pretty much a throwback to the 80s. You're still going to have lots of people with just very severe, apnea and so on. So the impact of weight is going to be clearly much more when you start off genetically with a pretty open airway. And weight is the driver of the narrowing. Now, weight will always drop oxygen during sleep for multiple mechanisms. So weight will amplify sleep apnea regardless of why you have the apnea, whatever age you are, and so on. But I would say that not more than all comers to my sleep clinic, 30% perhaps can have a very major improvement in their apnea by weight loss. Now, will they come down to a point where they don't need treatment? That's been harder to achieve. I have patients who have become very positional, like they were non-positional before they lost weight. But after weight loss, they become positional. Or they come to a range where they can use an oral appliance. Or they're willing to live with a certain amount of apnea and symptoms, just to be free of CPAP and such. You're talking about patients who have lost 80 pounds and that range, not those who have lost 30, 40 pounds. For that, it's a little harder to get cure. And also starts with your starting BMI. If you're 31, your response may not be that good versus being 41, as an example. So the way I explain to my patient is that if your BMI is higher than your AHI, that's a good start. If your AHI is much higher than your BMI, you're still going to have apnea. And how much apnea you're going to have left behind is going to be a little hard to tease out. But the way I look at the GLP drugs and any effective weight loss pharmacology, it's not going to be only GLP. There are other ones coming down. There are amylin options. And this is just we are just nicking the beginning of weight management pharmacotherapy.